In Massachusetts, public health departments have a lot on their plates. They weigh in on everything from trash violations to the opioid crisis response. A new report takes a hard look at the work of the more than 300 public health agencies across the state and offers recommendations for improvements. Laura Kittross is the Public Health Program Manager at the Berkshire Regional Planning Commission, and she's among those who worked on the report. She joined me in the studio to discuss.
We have this kind of unique system in Massachusetts where we have 351 municipalities, and because of home rule and because of the lack of county government and regional infrastructure, we have 351 boards of health. And just to kind of put that in perspective a little bit, the state of California has 61. We have 351.
It's a huge amount of perspective when you think about the size of California
exactly.
compared
like
to the size of Massachusetts.
I think there's about 3,000 in the country as a whole, and we have 351 of them. And we see this, it's a somewhat ineffective, or inefficient, I should say. It's not ineffective, there's a lot of good people working and people do a great job, but it's a somewhat inefficient way to deliver public health. So, that was one of the things. The commission was very interesting in that it wasn't just public health people. There were people from the Mass Municipal, the Max taxpayers, from a variety of other...
Some state representatives.
Town manager. And they weren't all, Department of Agriculture, they weren't all entirely familiar with the system. And they kind of came in and they heard this and they said, 351, let's just fix that. And we said, well, it's not that easy. And here are some of the things. So it was really interesting to have this kind of debate between us where people came from really different backgrounds, and we were able to have some very lively debate, as it's been described, and still come to conclusions that in the end everyone was happy with.
Well, let's look at a couple of those conclusions. Right now, there's an executive summary out of the 2 years worth of work that whole group of stakeholders did. A little later this month, we'll see the draft report, some public comment on that, and the final report in July.
Yep.
In terms of some of the recommendations that came out, is there one or two that stands out to you?
So, just talking about these 351 separate boards of health, one of the strong recommendations is certainly that there should be more what we call cross-jurisdictional sharing. Some people call that regionalization. It's simply taking a bigger population and a bigger group that might be able to hire full-time people, might be hire more qualified people, be able to put in some standard procedures, be able to have the resources necessary to not only do the day-to-day activities that the Board of Health has to do, the restaurant inspections, the septic systems, and so on, but also spend some time on some of these 21st century problems, chronic disease, substance abuse, mental health, and some of these other things that our small local boards of health don't usually have a chance to get to.
And it is a huge amount of work that these small boards of health are taking on. And, in the Berkshires, I know very intimately, you have a full-time director in Pittsfield, but then you have a board of volunteer folks who meet and discuss whether it's, a doctor on the board who have various areas of expertise. But they're people who are volunteering and answering to this one full-time person who might have a smaller part-time staff, maybe one other full-time person. So it's a lot of work that these entities...
And in the smaller towns, you don't even have that. In the smaller towns, you may have somebody who comes in for a couple hours a month to do some of the more technical stuff, and the rest is, like you said, volunteers taking care of it as best they can. I'd say the other recommendation that really stands out to me, just because I worked on it a lot, is workforce credentials. I think people aren't aware that in most situations, people who are doing the Board of Health activities, there's no state mandated or federally mandated workforce credentials, and they're dealing with things that are very technical and, like you said, a broad range of things that are very technical and have a lot of knowledge associated with them, and yet we don't mandate that they have workforce credentials.
Talking about the bulk of work that these boards have to do, whether they are full-time or volunteers, did the committee find that maybe some of those things should be spun off to other departments or other agencies?
No, I think we just feel like we need to give the resources and tools to the local public health folks so that they can do what they need to do. Another recommendation is around data, and making sure that the appropriate data flows both back up to the state so they can look at things as a whole, but also the data flowing back to the local boards of health so they can do appropriate assessment and figure out where they stand compared to other regions of the state.
And is that data on maybe rates of smoking, things like that, or what specifically are you referring to?
It would be everything from, have you actually inspected your restaurants and what violations did you find? Is there, are your septic systems failing? To things like cancer incidence and heart disease risk and rates of smoking and everything. So it would really run the range, and there's no centralized good way for that data to flow in either direction right now.
The idea of regionalization that we touched on at the beginning, I want to circle back to that. So as you said, California has far fewer boards of health compared to Massachusetts. But I do know that there's the Tri-Town Board of Health that works in Lenox, Lee, and Stockbridge, sort of three smaller communities in southern Berkshire County that are binding together. So would that be an example of regionalization here in Western Massachusetts?
So again, like I said, we're calling it cross-jurisdictional sharing now because there's a variety of models that would work. And in the Berkshires, as well as Tri-Town, which has been in operation since 1929 and is a full-service, comprehensive district that serves those three towns really well. We have the Berkshire Public Health Alliance, which has 24 members, but which is not that kind of comprehensive model. There are towns that the Berkshire Public Health Alliance provides inspectional and public health nursing services to, but then there's other towns that are just a member. And it allows the group to apply for grants that no one municipality would be eligible for, like opioid addiction grants, some food protection grants, as well as allowing them to purchase services on a contracted basis. So they have a housing case that they can't handle, they can come to the Berkshire Public Health Alliance. So there's about 15 regional structures across the state, all of which are different. Some of which were formed in 2011, which is the last time there was a grant program that was able to subsidize that kind of regional structures coming together. That's when the Public Health Alliance in Berkshire was formed. And then some that are much older, like Tri-Town, like the Quabbin Health District, like Neshoba, Foothills. So I believe there's about 15 of them, don't necessarily quote me on that, and they'd like to see, the commission and so on would like to see more of that kind of sharing. But, there's different ways that would work in different parts of the state.
Sure. For you, given your background in public health, your connection to it, you're very intimately aware of the intricacies of this type of work. But is there anything that surprised you in the process over these 2 years?
I don't think I'd ever thought of the data issue too much, and that, the importance of that feeding back and forth. Certainly it's been a frustration at times that I couldn't get the data that I wanted for a grant application or whatever, but understanding how important that is. But I think that one of the surprises is just, it's not really a surprise because I think I would have expected it, but that there is so little understanding out there of what the local boards of health do. We always say if local public health is doing their job, you don't even know they're there. But it really was a good process where people listened to each other and we were able to come to conclusions that everybody was really able to agree on.
So we have the executive summary available to the public now. A draft report will be available a little later this month, and then there's a public comment period. Yes. Is there anything that you hope the public will engage with or give information back to about this report?
Really, what I would ask the average person who is not part of a board of health is to be supportive of your Board of Health, to understand what they're doing to protect your health, to support them at town meeting when budget requests come up, because they're everywhere and they're keeping you safe. And we see huge disparities between towns that fund their Board of Health really well and towns that don't or can't. So it's really just being aware of what they do and trying to support them when that time comes in your town.